is kicking off another inspiring and informative episode with our distinguished guest to discuss very important topic. Today gonna talk about snoring in children. Besides that, we have other inventive and stimulating segment. Stay tuned for special episode. Once again, welcome back to Elixir of Life. Now we'll start with our first segment of the program. We'll be talking about the quote of the week. To watch more details about this quote, stay with us. Once again, welcome back to Elixir of Life. Now we are coming to the most important segment, our episode theme, talking about the dangers of snoring in children. Adults are not the only ones who snore. Researchers found that 20% of normal children snore from time to time. Snoring is not always a sign of a disease or pathological in children. In most cases, children who snore are perfectly healthy. Severe snoring is found in few percent or 2% of children and might be a sign of a disease, either sleeping disorder or breathing problem. To highlight more details about this disease, about snoring in children, it's my great pleasure and honor to welcome my distinguished and esteemed guest, Dr. Ameen Binnasser, who is ENT consultant, pediatric ENT consultant and head and neck surgeon. Hello, Dr. Ameen.
Hi, Dr.sheef. Thank you very much for inviting me today to this show. I would like to thank you and thank the Saudi TV. Also, I would like to congratulate our custodian of two holy mosques, King Salman, and his deputy crown prince, Prince Mohammed bin Salman, and all the Saudis about the 87th Saudi National Day.
Excellent, Dr. Ameen. Without further ado, we'll start first question. We have very interesting agenda today to discuss. Starting by what causes snoring in children?
Okay, so snoring, what is snoring? Basically, snoring is a noisy breathing that usually happens when the child is sleeping. What causes it is usually a turbulence of airflow that runs through the nose, nasopharynx, and oropharynx. So basically, any narrowing or obstruction in these areas will result in snoring at night. Most commonly in children is adenoidal and tonsillar hypertrophy. Those are the majority of cases. We cannot ignore the others, but those are the most common in healthy kids.
Excellent. How common is this, problem?
Well, I agree with you. There are variation in studies that actually measures the prevalence of snoring in kids. It ranges from 10 to 20%, and I'm talking about primary snoring, which is not associated with any other symptoms or signs. It's just a noisy breathing.
Mm-hmm. So you mentioned 10 to 20%. One or 2 out of 10 kids, okay, they
exactly
have
they
snoring.
do have snoring.
Okay, excellent.
Some part of their life.
Some parts. It could be mild, moderate, or
it could
severe.
be just a snoring, or it could be associated with what we're going to talk about later on, the sleep disorder breathing.
Excellent, great. What can I do if my child snores? That's important for parents.
So I'm talking about the kids, 10 to 20% of healthy kids who are not suffering from any even common cold, they will snore. So most of the kids, other kids, will have snoring when they're suffering from infections like a common cold, which is very common in this time of the year. So usually what happens, treat the acute infections, what I mean by saline drops to the nose, sometimes decongested for 3 to 5 days. Some humidification will help. Absolutely, if the kid is overweight, then reduction of his weight and encouraging him to more healthier diet and exercise will help for sure.
Excellent, Dr. Ameen. Having said that obesity is strongly associated with snoring, and obesity is common among children in Saudi Arabia. How frequently you see obese kids in your clinic complaining with snoring?
Well, I don't have the numbers right now, but frequently I do see kids who actually have no other cause to snore other than obesity.
Oh, that's why. Because obesity now, I think that's why they are highlighting the sports activity among the school.
Absolutely, and that's a very good move actually.
Excellent. So now we are coming to the next question. What should parents of children who are habitual snorers, to be concerned with?
Okay, so basically initially monitor your snorer kid, which means observe them at night. Sleep hygiene is very important, which means that if your kid goes to bed at 11 or 12 or midnight and then waking up about 5 or 6 a.m., they're not getting enough sleep, so I cannot actually judge their sleeping pattern. So the best is sleep hygiene. The kids, school-age kids, in the first 10 years of life, they require 8 to 10 hours of sleeping, continuous sleeping.
Excellent.
So let's start with that. Sleep hygiene should be monitored by the parents and actually they should force their kids to follow it. Also, monitor your kid. How long it will take your kid to fall into sleep. That will help the physician to assess what's the problem. Does he interrupt her sleep, him or her sleep? Does he open her mouth, gasp, or stop breathing while at night? Does he frequently move in bed or wet his bed? Sleepwalking or sleep talking. All of these, along with daytime symptoms, which range in kids from hyperactivity to actually a fatigue kid who looks tired all the time with a poor concentration. Those symptoms should be monitored by the parents. If they encounter one or more of those, they have to seek a medical advice.
Excellent, Dr. Ameen, because if the child, exerted a lot of activity, exercise, and during the day and the night, is it expected to snore because of the exhaustion and the fatigue?
Sometimes if they're doing an extraordinary activity, which is the activity that you don't usually do, yes, they will snore. They will not snore throughout the night, usually at the beginning of their sleep. Yes. The first couple of hours or 3 hours of their sleep, they will snore. But if it's something habitual, every night it's happening, then they have to monitor all the other symptoms. And there are a questionnaire in one of the slides that shows points where when the parents notice some of those, 8 or more of those, they have to seek medical advice.
Scoring system.
It's a scoring system. It's something for the families to look at. Whenever they notice 8 or more, they have to seek medical advice.
So we will project that in our slide.
Perfect. Yes, please.
Excellent. Dr. Ameen, because that the most important question, that come out, what's the difference between snoring among children and adults?
Okay. So there is a difference, first of all, about the cause of that, about the modality of treating those, the benefit of surgery in kids versus adults. And the effect in general, it's almost equivalent. Okay, let's start with, in adults it's more affecting males. In kids it affects both genders equally. However, there are some studies showing more male, but still it is equal in the variable studies. What causes it in adult? It's most of the time obesity. In kids, mostly it's hypertrophied adenoids and tonsils.
Great, excellent.
In adults, usually the daytime symptoms will be more of a fatigue adult. He will feel that his daytime fatigability, somnolence, tired, decreased productivity and concentration.
And they make car accident. Okay.
Exactly, increase the risk of accidents. And kids, it's more of hyperactive.
Okay.
They will be however, some kids will show some fatigability, but in general they'll be hyperactive and they will lose their concentration in school, and teachers will notice that.
Okay, so decrease school performance.
Exactly. For the treatment in kids, in majority of kids, removing the adenoids and tonsils when indicated will treat the problem. In adults, we're talking about a different field.
Excellent. Dr. Ameen, because you mentioned that the most common cause among pediatrics or children is hypertrophied or enlarged adenoid and tonsils.
Exactly.
Could you talk more about these, organs, so the benefit and...
Perfect. So the adenoids and tonsils are part of our defense system. They are lymphoid tissues located, and basically the adenoids in the nasopharynx, just behind the nose.
Excellent.
And the roof of the pharynx. And the tonsils are located in the oropharynx, just at the end of the tongue posteriorly. So they are part of the immune system.
So if you just, so you have this, picture about, you can comment on it about...
Okay, so here what's happening is the snoring, this and more showing the collapse of the tongue posteriorly and compromising the pharynx, the oropharynx in the lower picture.
Okay.
This is more in adults.
Adults, sure.
That happens more commonly in adults, where the tongue with the weight and everything is collapsing posteriorly and obstructing the airway.
Excellent.
In kids, it happens, but less frequent. In kids, we have a mechanical obstruction that remains there all the time, while they're awake or while they are asleep, and obstructs the nose, the back of the nose and the back of the throat.
Excellent.
So going back to your questions, yes, they're part of the immune system. They do secrete antigens that protect our upper airway.
Antibodies, immunoglobulins.
Antibodies, sorry, yeah, that protects our airway. But when they are causing problems, the harm of those tissues are more than the benefits the kid is getting out. And usually the immunity will not be affected if you treat it by removing those tissues. We still have a lot of lymphoid tissues in the area that do secrete what's necessary to protect our kid.
Excellent, great. So we try, as you mentioned, to keep them, to preserve them, but if they are causing troubles,
exactly,
they should be removed.
We only remove them if really they are causing problem to the kid.
Excellent, great. And which one is that more, that you encounter, causing troubles, the adenoid or the tonsils?
For sleeping and obstruction, usually it is more the adenoid.
Adenoid.
Because it is obstructing the back of the nose, which is the usual pattern of breathing through the nose. However, the tonsils, they are in the oropharynx, so basically, if they're not really hypertrophied and extending posteriorly, they will not obstruct the airway passage. They will cause difficulties in swallowing rarely. They will cause recurrent infection in some kids, but if they're not extending posteriorly into the airway passage, it will not cause a problem. So adenoids are more common than tonsils.
Excellent, great. And the next question, that how to assess adenoid and tonsil size?
Okay. So first of all, is from the symptoms. The parents, when they come to your clinic, answering your questions about sleep of the kid, that will actually increase your suspicion of the kid is having one of those. Then by looking into the tonsil, it will be much easier than looking into the adenoid. Just opening the mouth of the kid, sometimes you have to use a tongue depressor and look into the back of the throat to examine the tonsils. For the adenoid, you have two choices. First of all is passing a small camera, a flexible fiber optic scope through the nose. It will show us the adenoid, and also it will show us the posterior extension of the tonsils. Other way is using an X-ray, a lateral neck X-ray. It will show us both the adenoid and part of the tonsils.
Excellent. How easy to do that procedure, in pediatrics or in children?
It is doable. I will not say it's easy. It is doable. The younger the kid, the easier to control, where the parent can actually put him in his lap and control him. Absolutely, the kids will cry. They will fear what they don't know. So absolutely, this is something new for them, and they will cry, they will shout, they will try to move. But if the parent can control them, it will be better. And usually, I do prefer the non-radiological way, which is the scope. I don't have to expose the kid to radiation to see what I need to see. However, if the kid in older group, 8, 9 years, they are strong and still I could not convince them to do the scope, then doing an X-ray sometimes is better rather than putting him into a stress or fear of the clinic later on to follow. So do the X-ray will be much better.
So the scope, laryngoscope we call it, or
we call it nasopharyngoscopy.
Nasopharyngoscopy.
Yeah.
Does it need conscious sedation or I mean anesthesia, general anesthesia, or just
No,
done?
it's done in the clinic as an office-based clinic. It's a very, for kids, it's a very tiny scope, so no need for any sedation. Sometimes we use topical anesthetic medication in the nose just to help to calm the kid and decrease the sensation.
So it's a clinical procedure.
Exactly,
Okay?
it's a clinic-based procedure.
Excellent, great. And what can alert the family about sleep problem in their kids?
I'm sorry, can you?
What can alert parents about sleep problem in their kids?
So apart from what we said earlier in the questionnaire, usually what we encounter in the clinics where the parents say that my kid starts to hold his breath while he's sleeping, he gasps, he moves from one room to the other room because he's interrupted, and sometimes the kids feel the fear of holding their breath, so they will go to their parents at night. In older kids, usually it's school performance. There will be a change in the school performance, and the family and the school will notice that. So those are the two common things the parents will present to the clinic complaining about.
Excellent. Just my child, is complaining of snoring, and during night, and I notice him that, interrupted sleep. He wake up in the night and he go to the other room, as exactly what you have mentioned. Okay.
Yeah. So monitor him closely. If anything, then he needs an assessment
To be seen in your clinic. Excellent. Dr. Ameen, what about the relationship between nasal speech, and sleep, disorder and snoring among kids?
So what happens sometimes, the adenoid is in the back of the nose, and even the tonsils sometimes when they are huge, they will actually change the resonance of the speech of the child. So they will their voice or their way of speaking will sound like they're having flu or a common cold all the time.
Excellent, yes.
So that's just due to the obstruction. It is a mechanical obstruction. It is changing this just the resonance of voice of the kid. After treating those tissues or shrinking them, either medically for the adenoid or surgically, usually the kid will have his voice back to normal.
Back to normal.
Sometimes it will take up to 6 weeks to improve, but they will eventually go back to normal.
Excellent. Dr. Ameen, before we move to the treatment options, okay, for snoring among kids, if you would like to reflect on that image, okay, that's important. Do you have any comment about that, or shall we proceed? Okay.
Well, this is a lateral image, but unfortunately, it's not showing the tissues that we were talking about.
Which is the
exactly. If we can show a little later on
another slide. Okay.
Slide,
if you show us another slide, that will be important. And could you speak about treatment options for snoring? Okay, among kids.
Okay. So I'll say when a parent brings their kid to the clinic, and I ask them about the history, if it is suggestive of what we call a sleep disordered breathing, and he is healthy, otherwise he's not suffering from any medical problems, then we'll examine him. If he's having only an adenoidal hypertrophy, there is an option of giving a medical treatment, which is a nasal steroid spray. It is safe in kids older than 2 years.
First line treatment.
First line of treatment. It shows an effect, and it will improve and shrink the adenoid in up to 50% of cases.
How long does it take, the treatment?
Good. That's a good question. The treatment should extend up to 3 months in a daily basis. However, if after the first 6 weeks there is no improvement, we have to stop it. It means it will not work.
So the initial improvement start after 6 weeks?
6 weeks.
6
if
weeks
there is an improvement, those kids will continue another 6 weeks for a total of 3 months, and then reassess them 1 month after stopping the medication. Excellent. At least. The other option, when they have an adenoid and tonsil hypertrophy and they are symptomatic for a good time, it's not only during a cold or during an acute infection, then the treatment is removing the tonsils and adenoid out surgically.
Excellent. Surgical resection. Okay.
The third option, which has some limitations, it will be done in kids who are not fit to go for surgery, which is CPAP. It is also used in kids after removing the adenoid and tonsils with persistent problem, or kids with other congenital or medical problems that require the CPAP. So it is an alternative treatment, but it's not as effective as removing the mechanical obstruction
surgery. You are not candidate for surgical intervention.
Exactly, that's the best thing.
Excellent. Would like to talk more about the surgical resection or surgical removal of the adenoid and tonsils. So what are the state of art advances in this field? Because all of us, during, I would say childhood, experienced, removal of the tonsils under general anesthesia and etc. So what are the state of art advances in this field?
Well, it's just a newer modality to remove them, but however, most of the things are the same. So usually what happened, most of the people most of the older generation, they're removing the adenoids and tonsils by what we call cold dissection, which is a perfect way to remove them, curate for the adenoid, and removing the tonsils by forceps, dissectors, and controlling the small bleeders by packing the nasopharynx and cautery or ligation in the tonsillar beds. This is still unacceptable and widely used up to date. The newer thing is to do it using an electrocautery, the adenoids and the tonsils. It will shrink it will shorten the operation time. It will decrease the bleeding inside the surgery, but reportedly it might increase the pain after surgery. For the tonsil, there are techniques now used to actually what we call intracapsular tonsillectomy or tonsillotomy, where we removed most of the tonsillar tissue but not completely. And there are more than one way to do it. However, all of them share that they remove part of the tonsils, ensuring that all the crypts of the tonsils are removed and only a small layer of tonsil is remaining on top of the bed. It is reported that this technique minimizes the bleeding and the pain after surgery, which means as a complication from surgery.
Excellent. We'll talk about complications. Dr. Ameen, is it a day, surgery procedure or it needs, operation room? Okay.
Yeah, it is a day procedure in most cases. However, some kids, depends on their age or their medical background, they might need an overnight admission in the hospital, and rarely they might need even an ICU admission.
But day procedure, can you just explain it more? What's the procedure?
Perfect. Day procedure means that the kid will be seen in the clinic, evaluated. If he matches the criteria to have the surgery, he will be evaluated by the anesthetist.
Excellent.
If the anesthetist clear him, then the patient will be instructed to come on the day of surgery fasting, depend on the operation time, and he will come to what we call a day surgery unit. He will come over there. They will be seen by the nurse, seen by the physician, assist if he's fit at that day of surgery. Yes. He's not having any cold or any contraindication to go under anesthesia. After the surgery and recovering in the recovery room, he will send him back to the day surgery unit. In the evening or after surgery, patient will be discharged home. So the patient doesn't need to be admitted physically to the hospital. It's a unit. It's like an outpatient unit. We call it the day surgery unit.
Excellent. That's to avoid, hospitalization and
exactly
decrease the hospital, hospitalization cost and effective utilization of the resources.
Absolutely, yes.
How long does it take the surgery?
Usually it takes, if removing adenoids and tonsil, 20 to 30 minutes surgical time, apart from the anesthesia time.
Anesthesia clinic. And if it is only adenoid?
Usually it's 10 minutes.
And tonsils?
Another 10 minutes.
Another 10 minutes, okay. And what's the appropriate age for, kids to go for surgical removal, okay, if you decided that?
Perfect. So let's agree that when the patient needs it and he is symptomatic and it's causing a problem, then surgery should be done. However, each age has limitations and has some guidance to actually post-operative care. It is generally recommended not to do tonsils below the age of 3 years.
Okay.
Unless it is really causing a problem, then removing the harm is better than keeping it. And those kids usually will require an admission to the hospital, the younger the kid.
Younger the kids, more, anticipated complications.
Exactly.
Excellent. So this is leading us to the complications. What are the complications, of these, surgery, adenoid and tonsil, removal, and how common these complications?
Okay. So as I mentioned earlier, the procedure is short. It is surgically, and from the anesthesia point of view, it is generally a safe and easy procedure in general. However, it is very painful for the kid after surgery. They will suffer significant pain for 7 to 10 days after surgery, and I'm talking about real significant pain. This area, especially the tonsil, I'm talking, not the adenoid, it is the passage of air and food, which means whenever the kid is swallowing, he will have pain. Whenever he's breathing, he will have pain. So pain is something major, and families should be actually oriented before surgery how to deal with pain and what to expect from their kid after the surgery. The second thing is bleeding. It is not common. It happens. It ranges from 1 to 3%, and we're talking either a primary bleeding within the first 24 hours after surgery, or secondary bleeding that happens after that up to 10 days and sometimes up to 14 days after surgery. This bleeding can range from a small spots of blood noticed by the family, or actually spitted out by the kid if he's older, or sometimes it will be something more life-threatening, active bleeding that requires immediate surgical intervention to control that bleeding. This is something that when I speak with the parents about surgery, they will be surprised. They've never heard about that. What are you talking about? What is this bleeding? This is a simple surgery that everyone had it before. But this is something serious that parents should actually be aware and know how to deal with it. They have to go to the nearest emergency if their kid is bleeding. Time is very important at this point. It might be an active bleeding, so it might obstruct the airway or might end up with a hypovolemic shock for the kid. So he needs to go to the nearest emergency room where he will be assessed, and sometimes they need to push him to the operating room to control this bleeding.
Excellent, Dr. Ameen. I think that's why it's very important to, surgical assessment, history taking, physical examination, family history of bleeding disorder, or personal, history of bleeding disorder, checking the labs, anesthesia, pre-anesthesia clinic, so that to make sure that the child is fit for surgery.
Absolutely. And for the labs in general, if you have a good history, if you take from the family a very good history and he is healthy kid, no need for any labs.
Like coagulation.
No need for any coagulation, unless there is something in the history that points you toward that, or the family history especially. But if he's a healthy kid who had a previous surgery or multiple wounds that never bled prolongedly, and his family history is negative, he's healthy, and he doesn't look pale, then you don't need, in general, any labs.
Excellent, Dr. Ameen. So this surgery is safe, is benign procedure, but however, we should be aware about the complications, that might happen sometimes. Thank you, Dr. Ameen. Now we'll go for a report about snoring in children. To watch more details about this report, stay with us, please.
Obstructive sleep apnea is a common type of apnea in children. It's typically caused by an obstruction in the airway, such as enlarged tonsils. One of the many symptoms includes snoring, and treatment is often the surgical removal of the tonsils and adenoids. So if your child snores, they should have their tonsils out? Is this myth or medicine?
If your child snores, they should have their tonsils out. That is a myth, and I'm going to tell you why. I'm Heidi Connolly, and I'm the chief of the Division of Pediatric Sleep Medicine at the University of Rochester Medical Center and the Golisano Children's Hospital at Strong. Probably about 8 to 10% of preschool-aged children snore, but only about 2% actually have sleep apnea. So if every child who snored was going to have their tonsils and adenoids taken out just because they were snoring, we would be doing surgery that's not necessary. Taking out tonsils and adenoids is a relatively low-risk surgical procedure, but it's still a surgical procedure with the attendant risks of getting general anesthesia, recovery time, time off of work, and time from school.
What is the correlation between obesity in children and sleep apnea?
Having obesity increases the risk of having obstructive sleep apnea because it narrows the airway due to fat deposition in the tissues of the upper airway. The converse is also true, that having sleep apnea increases the risk of obesity because of the sleep disruption, leading to more sleepiness and sedentary behaviors during the daytime. Treatment of sleep apnea is known to improve linear growth in children, so taller children who weigh the same are more thin, and also helps with weight loss because children are more engaged in activities during the daytime and therefore less likely to be sedentary and have excess weight gain.
Once again, welcome back to Elixir of Life. It's my pleasure to welcome back my distinguished guest, Dr. Ameen Binnasser, to talk about snoring, the dangers of snoring among kids. Welcome back, Dr.
Thank you very much,
Okay.
AlSheef.
Just to continue our, wonderful discussion about this important topic, we paused on treatment options and ended with a surgical removal of tonsils and adenoids and complications. Now we gonna shift the gear to important related topic is the fluid in the ear. Shall we act immediately or wait?
Perfect. So building up a fluid behind the tympanic membrane, or what we call in the middle ear, it is very common, and it is more common than having sleep disorder breathing in kids, at least in the general practice. That's what we see. And for surgical intervention, it is more common than the previously mentioned procedures. So whenever the kid have a flu, have a common cold, he will end up with building some amount of fluid in behind his ears. It can happen in adults, but it's more commonly due to anatomical issues. It is more commonly in kids.
In the middle ear, fluid in the
Exactly, fluid in the middle ear. The eustachian tube that ventilates and drains the secretion fluids out of the ear, it is in kids more in a horizontal orientation rather than in a semi-vertical in adults. So any inflammation in the area, in the nasopharynx, it will be congested and it will actually accumulate the fluids that's the ear actually secretes, it will accumulate in the middle ear. So if a child presented a clinic with a recent history of decreased hearing, it's just for the last couple of weeks or following a common cold, then just wait and see. A majority of those kids will resolve this problem within the 3 months after the infection cleared from the kid. So initially, no need for an immediate act. Observe, document, and monitor the kid closely for this problem. Sometimes in a child who presents, especially the school-age children, who present with a long history but never been actually assessed or documented that he's having a fluid of hearing loss. Family brought him to the clinic with a long history of hearing loss. And you assessed him and you found signs of fluid behind the drum. Then he will need a hearing assessment. If the level of hearing assessment indicates what we call a higher degree of hearing loss, around 30 decibel of hearing loss, which is, it can happen with fluid, but it's the higher level, then those kids, because of the effect of fluid and hearing loss in their school performance and their learning, then acting immediately will be more recommended than observation.
Excellent, Dr. Ameen. So what's the relationship between the fluid build-up in the middle ear and snoring? Okay.
Perfect. So the opening of the eustachian tube will actually, it is located in the lateral wall of the nasopharynx. The adenoids build up from the posterior and superior wall of the nasopharynx. But what happens that when the adenoids get bigger and bigger, they will obstruct the opening of the eustachian tube, and it will build up fluid in the middle ear. So it is closely related. When a child is having fluid in the middle ear, in case he's suffering from snoring.
Great, excellent. So they can have snoring, they can have hearing difficulty. What other symptoms they might experience? Okay.
Sometimes with the buildup of fluid, apart from the hearing loss, they can present with what we call an stability issue. They will fall out frequently.
Equilibrium, okay, the balance, okay.
Exactly, a balance problem. They might, in an older kid, they might present with actually a vertigo, but they have to be a little bit older to actually explain what's going on. In a younger kid, they will have an equilibrium problem or a balance problem. It's not very common, but it can happen, and whenever a kid presents suddenly with no neurological problem, with a balance problem, his ears should be checked.
Excellent. After diagnosing fluid buildup in the middle ear and need treatment, what will be the treatment options for this? Okay.
If a child presents to your clinic with otitis media with effusion, and he is having this history for unknown period, but it's not affecting at this time his school, then the best treatment is close observation up to 3 months.
3 months.
And get him back, reassess him, do a hearing test at that point, and document the fluid. No proven medical treatment for this problem. However, unfortunately, what we're seeing in the real practice, kids are giving antibiotics, they are given large doses of oral prednisolone or steroids for sometimes long time, up to 1 month, given some nasal medications, anti-allergic medications, all of them proven not to be effective for fluid. Fluid in a majority of kids will improve by itself within 3 months. So after given the 3-month period of observation, then reassess. If the fluid is still there, then the only treatment available is what we call a ventilation tube or a laryngotomy, where we cut the drum under the microscope and place a tiny tube in the drum to actually ventilate the middle ear.
Excellent. So this is surgical,
surgical
option. Yes. After exhaustion of the medical options, you mentioned steroid. Is it really effective, or it's unnecessary?
It's absolutely unnecessary and no effect of it. Unfortunately, it is given to a lot of kids, but no benefit from this medication.
So it's wrong practice. You don't.
It is an old practice.
Old practice. Okay. Nowadays, not recommended in the guidelines.
Exactly. All the guidelines are against giving any medication to treat the otitis media with effusion.
So whether it is nasal steroid or systemic oral steroids.
Exactly.
You don't recommend for it because of the complications of the.
Because it's not showing any effect, and the harm of the medication exceeds the benefit that we expect from it.
That's why medicine is dynamic, it's not static. In the past, maybe proven benefit, but nowadays
it's not proven. Yes, absolutely.
Yeah, because based on the evidence, based medicine and clinical trials. And is there any home treatment for this? Okay, or only done?
Multiple trials actually showed, or actually experienced some not a medication, it's just something to open the eustachian tube.
Okay.
It's like a puffer that you'll train the kid how to do it. You'll put it in the nose, it will puff air in a higher pressure to open the eustachian tube. However, the companies that actually made this product, they are advertising and showing some studies, but all the guidelines still does not accept it as a modality of treatment. Yes. No harm monitored from these medication. If the family want to try it, it's fine. And while they're waiting for the first 3 months for assessment, but it's not proven by studies that it's effective at this time. Maybe later on, but at this time it's not proven.
It's a device, okay?
It is a device, yeah.
And is it available in Saudi Arabia, or it's only in the Western world?
At one point it was available. I'm not sure now about the availability of this, because they actually presented, some of the companies presented in one of the otolaryngology or ENT meetings here in Riyadh. They presented and they said it's present in the market, but I'm not sure if it is still available.
Excellent, excellent. So you are doubting its efficacy, and
it's. Let me make it
clear.
More clear. There is no strong evidence to support it.
Excellent. Okay. And the other, we talk about the surgical, insertion of tube for drainage of the fluid, or you call it
a ventilation tube or pressure equalizing tube.
Okay. Can you talk more about this? Perfect. The surgery. Is it a surgical procedure or day procedure, and elaborate more about the complications and etc. Okay.
Perfect. So it is a day procedure. It is done in, let's just move a little bit. In adults, it can be done in the clinic under local anesthesia. Just putting a cream, anesthesia cream in the ear of the patient, and you can do it in the clinic while he's sitting in your room, in your office. In kids, you cannot do that, absolutely, because they will be afraid. So if you're doing only this type of procedure, patient most of the time will be a day procedure. And in majority of kids, they will not even need an intubation to ventilate them. Most of the time, they'll just need a bagging or mask ventilation and sedation, and proceed with the surgery. The surgery itself, it's a very short procedure done under microscope, and generally done under microscope, where you just examine the tympanic membrane of the kid and the external canal. After that, you will incise the drum and place a very small tube with, generally we're using the outer diameter is, the diameter of the tube is around 1.14 millimeter, ranging from 0.76 to a bigger tube. So it's really a very tiny tube. The aim of the tube, actually, it's not the drainage of the fluid.
Ventilation.
Exactly. It is a pressure equalizing. It will help the eustachian tube to regain its normal function by equalizing the pressure of the middle ear. So it will force the fluid and the eustachian tube to actually drain
the fluid.
Exactly. So it's actually something that equalizes the pressure in the middle ear.
Excellent. What are the, it's safe procedure?
It is considered a very safe procedure. Complication rate is very low, and we're talking about around 1% of patients who undergo this procedure, they will have a permanent hole in the tympanic membrane or the drum after the tube falls out.
After the tube falls out?
Yes. Sometimes the kid will have, after placing the tube, they will have recurrent or persistent drainage from the ear. And there are multiple causes from this. It could be infection, it could be the material of the tube itself. Sometimes we need to change the tube from, let's say, plastic material and inner to something more metallic, a titanium tubes. Just sometimes to overcome this rarely happening complications. But in general, it is one of the most common procedure performed in kids worldwide. It is more common than doing even adenoids and tonsil, and it is one of the safest procedures to be done.
Excellent. Once we insert the tube, the ventilation tube, you keep it for life, or should be
No, usually
changed?
what will happen, it will fall by itself within the first 18 months after the procedure. We usually inform the patients between 6 and 18 months the tube will fall out. He will need, or she will need, an follow-up, and a regular follow-up in the clinic, just to assess the tube, assess there is no complications, no tissues growing around the tube. And if it doesn't fall by 18 months, we will wait another maximum 6 months up to 2 years. After that, we will pull it ourselves. Why do we not remove it immediately? It is painful when you try to remove it. So in kids, you cannot do it. So better to do it under anesthesia.
Excellent. And after, insertion of the ventilation tube, snoring will improve of the kids, pediatrics?
After removing the adenoids, snoring hopefully will improve in at least, let's say, 70 to 80% of kids after removing the obstruction, adenoid or tonsil or both. And it will take time to improve. But after putting the tubes in the ear, majority of kids, they will have back to normal hearing immediately after the surgery in the first day.
Excellent, excellent. Dr. Ameen, we are coming to the end of our program. What are the take-home messages, okay, you would like you to send to our dear viewers, okay?
Okay, perfect. So please, if your kid is having a very disturbed schedule of sleep, where they sleep by midnight and then they nap after school for 4 or 5 hours, this is absolutely unhealthy for the kid. So please, sleep hygiene is mandatory for the kids. If your child snores for a long period, for months, other than the time he's suffering from cold or infection, monitor him for symptoms of what we call sleep disturbance, interruption of sleep, movement in the bed, bedwetting or enuresis, sleep talking, sleepwalking, holding his breath and gasping while he's sleeping. Monitor him in the morning when he wakes up. Ask his teacher about his performance or any change in his attitudes, in his concentration, activity. And if you find that there is something going wrong, please consult a physician about that, either your family physician, pediatrician, or an otolaryngologist, ENT surgeon.
ENT surgeon, okay. Thank you, Dr. Ameen, for enlightening us about this important topic. It was very informative discussion, and I really appreciate you for being with us, and would like to see you in the near future in other episodes.
Thank you very much, Dr.sheef. Appreciate it, and appreciate your show and your work. Thank you very much.
Thank you very much. Now we are coming to the end of our program. Before I conclude, ladies and gentlemen, I wish that you have enjoyed our episode and found it useful, informative, and motivating. And I would like as well, appreciate our great team for their great work. And until next week, we wish you a pleasant week ahead. Assalamu alaikum wa rahmatullahi wa barakatuh. See you in the next episode.